Oh, really? On a Monday?
Yes.
I
But
see. I see. We have a. Uh, is it Dr. Michael Oye?
yes,
He's yawning now. That's my namesake.
Papa, welcome, sir.
Oh, really? On a Monday? Okay,
Yeah,
I'll ask
Oh,
that.
hello,
I
but
see. I see. We have a. Uh, is it Dr.
Herbert.
Michael Oye?
Herbert,
Yeah, Yeah, Herbert. Yeah,
how
yeah.
are you?
I'm doing well.
Good.
Good evening, sir. Welcome,
How are
sir.
you, my daughter?
Fine,
Good.
thank you, sir.
Good.
It's so nice to have you on tonight, sir. And welcome, everyone. Um, Incredible Monday. Dr. Oye was just asking me how my day went. And yes, I'm just coming from a birthday party from my sister's birthday party, whose birthday is today. She turned 70 today, and it's
Wow.
my
Mm,
birthday tomorrow.
Wow.
So I decided to go hang out to, celebrate pre-birthday for me too.
That's good.
But she kicked me out of her house to come to Medical Mondays. So here we are. And thank you so much, um, Dr. Oye. So tonight we have our very own family, Dr. Herbert Oye, endovascular and vascular surgeon in Virginia, who practically just came out of the emergency room. He got stuck. Sorry,
Operating.
emergency room, operating room. I
Operating.
kept saying operating room, and he's still willing to educate us tonight, to impart knowledge into us, and we're very grateful. I am Dr. Toyin Okpesomi, family practitioner who also treats HIV and substance use disorder in Maryland. And I'll be hosting tonight as usual. But I'm going to yield the floor to Dr. Oye because, we would like him to go home to rest as soon as
Mm.
possible. So the floor is yours.
Well, thank you very much. With me this evening is student Dr. Ibrahim Ibikunle, who is third year going on fourth year medical student, and he has done his vascular surgical rotation under my care several months ago. So he's an expert himself. He literally can give his talk. But I
Nice.
will do it because I promised I was going to do it. Um,
Thank
Essentially,
you. And
welcome everybody.
welcome.
Welcome everybody, and we want to make this straight to the point, and have to be. I'll divide the talk into two phases. Phase one, I'll talk about critical limb ischemia, which is important. In phase two, I'll talk about how we can make vascular surgery uh, feasible in Africa and in rural America. I'm in West Virginia. I've been in West Virginia since 1997 when I finished my fellowship and at the Arizona Heart Institute. And I came to West Virginia at that time when the hospital I worked in Clarksburg was a very nice hospital, had no had one cardiothoracic surgeon, but it didn't do any endovascular surgery. So I literally came from a high-powered training program in Arizona and came to West Virginia and was able to just start a program, endovascular surgical program in Clarksburg in 97 through 2005 and built a program there from nothing to something. It's one of the better programs in the country at this point. In 2005, I then made a lateral move to Beckley, West Virginia, which is now about 2 hours away from Clarksburg, and again came to the community. There were two hospitals about maybe 7, 8 minutes apart. And again, zero endovascular presence. Again, I started two programs here in both hospitals and made that work. Then I went to a sixth hospital, fourth hospital, and a fifth hospital within another 45 minutes from here, and also did the same. Then in 2013, after been in practice for so many years and after amassing so much skill set and knowing what to do, what not to do in surgery and defining surgery from my own perspective, I trained in New York, which I'll talk about later, and trained in Arizona. So I would learn from very famous vascular surgeons both in New York and Arizona. But when I came to West Virginia in 97, I wanted to create my own identity. I could have stayed in New York, I could have stayed in Arizona, I could have stayed in Texas, but I came to a community which had zero endovascular person. And I thought in that time, it was better to do that. And it worked out well for me. So that has been the history. So in 2013 or 2017, we started an endovascular program in Bayelsa, Nigeria, and then 60-bed hospital, the Bayelsa Specialist Hospital, and that's working well. And it does have not only vascular surgery, it does have cardiology to some extent. It has pediatrics and internal medicine. So it's actually working to serve the people. And as time has evolved, about 2020 or so, we decided it was time to take the show on the road to Lagos. So we went to Lagos, and in Lagos, we were able to become consultants for multiple hospitals in Lagos, Duchess, Lasu, Luth, FMC, Evercare, then we Abuja, and so Port Harcourt. So I do all that every 2 months. I go to Nigeria with the sole purpose of improving healthcare, particularly endovascular vascular healthcare in Nigeria, and so ensure that our people don't die unnecessarily because. Which I'll talk about it later in the talk. People die in Nigeria because they don't have access to care. And that's one of the problems. So that, in a nutshell, I will talk about my rationale for doing this as I go on during the talk. So let's start now by saying something that's quite important. Okay, every person in this platform today, yourself, your family, your friends, one or some of them will develop a case of peripheral arterial disease at some point. The question is when and what we'll have to do when that occurs. So the title of the talk is Critical Limb Ischemia. Yeah. How we management critical limb ischemia as the first talk. So let's get started, Doctor. I'm going to share the slides now.
Excuse me.
Yes. And disabled screen sharing. Can you share? Just say host disabled participant screen sharing. You have to help us out, Doctor. Critical limb ischemia is important. The reason why we say it's important is peripheral arterial disease in itself affects in the US alone 10 to 12 million people. Worldwide, PAD, peripheral arterial disease, affects 247 million people worldwide. So by numbers, that's a large number of people that are affected. Just like you have heart attack, you have stroke attack, you literally can have limb attack, which is equivalent for critical limb ischemia, can cause one to lose their limb all their life. So it's just as important as a heart attack or stroke. Next. In the US alone, over 200,000 amputations occur per year in the US. That's a high number. In developing countries, especially Nigeria, these numbers are what we see in Nigeria. 65 to 80% of persons in Nigeria with critical limb ischemia may end up with primary amputation as their final goal. So that reason is simple. They don't have enough endovascular vascular specialists or cardiac thoracic surgeons that do vascular surgery to get in to help them mitigate the problem. So the only thing they know is cut a leg off. So again, even in the United States, you would be amazed how some persons would go to some institutions and without any vascular workup, where the limb could potentially be saved, the primary instinct by the general surgeon, whoever's taking care of them, orthopedics, to cut the leg off. Again, that's the reality. Again, now, if this occurs in the United States, think about what's going to happen in developing countries. Think about what's going to happen in Nigeria, population over 232 million people. It's a major problem. Next. Well, you have to talk about the pathophysiology of this problem. Main culprit is atherosclerosis, just plaque buildup. For the physicians, not for the non-physicians in the audience, atherosclerosis simply means the plaque buildup within our arteries. When these patients have advanced calcium buildup from these arteries, it interrupts the blood flow to the lower extremities. Remember, the heart generates a lot of blood to our body, all parts of our body. If the plaque is significant and the blood does not reach its target, i.e., the toe or the foot, then not enough oxygen will get to that part of the body. When we don't have enough oxygen getting there, then that translates as pain. What the patient feels is pain. The pain is because number one is lack of blood flow, not enough blood go through, and number two, because there's not enough blood going through, there's therefore lack of oxygen. So when they exercise, walk, even go to the mailbox or do a limited walk, they get a lot of pain associated with it. Again, this may then result in, if they have wounds or ulcers that are not healing, it can then progress to tissue death or gangrene. The worst case scenario is once you have gangrene of a foot. If you have a gangrene of a foot or leg, if the gangrene is dry, you may be okay. Depends on the extent. If the gangrene is wet, and then sometimes that person may need an urgent amputation. It's important to note that there's sometimes we may need primary amputation where it is inevitable. Somebody comes in, they've had critical limb ischemia for 1 month, never showed up to the doctor's office, no person has seen them, and all of a sudden they showed up in the ER, and the foot is foul smelling, it's gangrene, you have maggots growing out of it. They need an amputation. You don't need to be a vascular surgeon to know that person needs an amputation. That's when an amputation undoubtedly is needed. There are two schools of thought when it comes to amputation. One school of thought is just amputate. The other school of thought is limb preservation. I belong to the school of limb preservation, where we do everything possible to save the limb. If I have to amputate the leg, trust me, there's no other option for that person. They need to have the leg cut off. But some doctors don't even surgeons like I am, just proceed with amputations purposes. Yeah, hold on. Yeah.
The relative, the wife has
I'll be there.
concern, and then
Pardon me.
it's just that they wanted to know if they are gonna stay here for the night.
Of course.
They'll be admitted and stay here for the night.
Yeah.
Okay. And they're asking if there's no chance that they can be discharged.
No.
After? Okay.
Yeah, till tomorrow. Yeah. So the risk factors again are atherosclerosis. The other one is hypertension. Again, that's a major problem that we have worldwide. Again, if you take 5 people in a given audience in Africa, 3 or 4 of them have high blood pressure. It's a major problem. And high blood pressure not only affects peripheral artery disease, affects strokes, affects people with heart MIs or heart attacks. So if we can control our blood pressure, we can do a whole lot more to avert a lot of bad things that occur. Smoking is a major problem in the USA. Smoking in Nigeria is not as much, but you'll be surprised that the disease process is just as bad, even though we don't smoke as well. That then tells you that the root cause of the PAD in Nigeria, for example, African countries, more hypertension driven or genetics and diabetes. In the United States, smoking is number 1, diabetes and sedentary lifestyle as those atherosclerosis. Next. The practice. Endovascular therapy options became more relevant in the early 90s. When I was in training in general surgery, at that time, endovascular surgery was not very well recognized. The older surgeons wanted to just cut and do a bypass. Then this technology of minimally invasive technology came along. And as that came along, we started to do things in a minimally invasive fashion. Some of those doctors became converts. As a matter of fact, my trainer in endovascular surgery was a heart surgeon, Dr. Edward B. Dietrich, and he was an excellent surgeon and also an excellent endovascular surgeon, and he was one of the pioneers of endovascular surgery. When we do endovascular surgery, certain things that uh, uh, it's important for you to have capability for this patient to have ultrasound as part of the workup, CT angiogram when feasible, catheter directed arteriogram or dye test when feasible. Yeah, but
Tara was trying to check her way through with that. She's.
he needs to stay overnight. Yeah, because if it doesn't work, he needs a permacath tomorrow. So when it comes to PAD, when you do a PAD work, you have to be able to have CT angiogram capability, the ability to intervene using catheters to diagnose the problem and treat the problems. And most cases of severe critical ischemia usually involves the arteries below the knee. It's called the tibial arteries. Next. When is endovascular therapy necessary for chronic limb ischemia? When it's necessary to improve blood flow in the thigh to knee area region to provide straight flow to the lower extremities to prevent amputation or save the limb. Where must have a balance of risk versus benefit ratio of prolonged intervention, the diet that we use to treat these patients, and other comorbid conditions such as heart, lungs, and kidney. All those things would predict how much we have to work on these patients. Again, when you do surgery, you sometimes have blood clots that can escape and go downstream. That's called embolization. When it goes downstream, it's called distal embolization. That's one of the complications that, when recognized, we fix at the same time as surgery. Aggressive intervention to solve this problem is necessary sometimes to prevent limb loss. Tibial arteries, the arteries, which are the arteries at the knee level and below, are the two most common areas for chronic limb ischemia interventions. Again, we approach the problems from different directions. We can approach a problem from the groin area. We can approach a problem from below the knee area. We can approach a problem from the ankle area, just to ensure that we make a wire go through a blockage to treat and ensure or restore flow. If we are going from the ankle or from the knee area going up towards the heart, that's called a retrograde popliteal or retrograde pedal approach. If we're coming from the groin going down, that's an antegrade approach. If we're coming from the elbow, you sometimes can come from the elbow or even the wrist to treat the leg, and that also is a retrograde approach. Next. So some strategies we use to treat patients are we have a toolbox, and in this toolbox we have a lot of things we can use. So we have to decide based on what we're seeing, based on the testing, what's the next best test. Balloon angioplasty is one, cutting balloons is another. Intravascular lithotripsy, which is the same technology as when you hear about people having kidney stones that have been blasted, is the same technology. Endarterectomy, hybrid surgery, and open bypass surgery. Next, please. Yeah, yeah, it's fine. Put it on hold. Okay. All right. This is for the non-surgeons. This is a trial which compared balloon angioplasty and bypass surgeries in patients and the benefit of either. The endovascular technology appears to be equivalent to doing open bypass surgery. Open bypass surgery is more invasive. You have to have a cut, maybe more than one cut to restore flow. Endovascular surgery, you make no cuts at all. Sometimes just balloon wires, and you treat the area and you restore flow. There's a 20% technical failure rate associated with the above. The results are better with improved balloon. Balloons are better now. With intravascular lithotripsy now, as the technology with ultrasound guidance, it works very well. And we sometimes can avoid doing bypasses in patients. Bypasses, like I said, is more debilitating depending on the location. Sometimes we can do bypasses between the belly button and the hip. As big surgery called aortobifemoral bypass, you open make a cut from the chest to the pubic area. move the intestines away. If the aorta is clogged up, you can do a bypass. That's big surgery. Many years ago, we did a lot of that. Nowadays, we have a technique where we don't have to do that as much. We just make cuts to the groin instead and put wires up, make wires go through blocked arteries and put stents in. That condition is called a CRAP, which is covered vascular repair of aortic bifurcation. So that works very well. We do a lot of that now. So we're able to avoid patients having the need to have open surgery, which is quite debilitating. And sometimes you have open surgery such as that, you might be in the hospital for a week. It'll take you about a month to 6 weeks to recover. With endovascular surgery, you're able to go home same day or the next day, and you get back on your job within 48 hours. Next. So let's talk about a few cases to bring it back to light. The first case here is a 68-year-old female. She had an aortic bifemoral bypass, which same surgery I talked about 13 years before, and left fempop, which is the thigh to knee bypass. She's a smoker. Presents with advanced ischemia of her left leg with rest pain. And she had a CT angiogram done, and she had extensive clot in the left limb or left segment of the aortic bifemoral bypass to her foot. Next. Again, our procedure was to open the left groin area. We put the balloon and took the clot out and restored flow. Next, please. Again, so this is a patient again. Extensive amount. She didn't show up at the hospital on time. So you could see her leg is really advanced. I mean, it looks really mottled. She has blisters. It just looked pretty bad. Even though we restored flow, sometimes patients come to you so late in their course, even though you do such a fantastic job to restore flow, their body does not even recognize that as their own body. So they end up needing amputation. Next. So that's a advanced form of critical ischemia with severe patients. So when you have a family member or friend having a leg problem, you don't want to get to that stage or that picture you've seen. You want to engage them a lot sooner. Okay. Next. So you can see where we're doing surgery, do a bypass. You see the tube on the right side, bypass connected. Okay. From the bypass, we took the clot out. Next. And next. And we restart flow. So this is a CAT scan on the left-hand side. You can see there's no flow on the left-hand side. The right-hand side, you can see the flow going down. So she had a lot of work done. You can see the image in the middle. You can see a wire going through it, and where made a wire go through that bypass. And you can see on the far right, you can see we restored flow. Next. And we balloon that area. We restored flow, but again, we're able to restore flow to the top portion. So even if she were to get an amputation because we restored flow to the top portion, the amputation area would heal with less pain. If we're not able to open the left portion of that area, even if you do an amputation, it may not heal, and you may have to do what we call hemipelvectomy, literally going out there and actually removing the entire hip from its socket, and that's really, really debilitating surgery. Next patient, patient came to the ER. The patient had a CT angiogram demonstrating blockage of the iliac arteries on both sides and a fempop need to hip to knee artery occlusion, fempop occlusion. Next, we could see again the test on the left-hand side. You could see the right side looks nice flow all the way down the foot. You're looking at the image is reversed. You're looking at it. And then on the left side, you could see some portions missing. Again, we're able to now go through and treat from area. You could see where it starts at the top, the blocked areas at the top. So you can see a balloon going on the big image to the right. We're able to balloon that to restore flow. Next. And we balloon both sides and we restored flow on that area. Next. And we see some more balloon going there. Okay, this is the endovascular technique. Next. So you could see the balloon on either side now. We can see we'll put 2 stents on either side to restore flow. Next. And see the middle picture shows the final image there from not much to a lot now. And you can see some of the plaque we took out as part of the process on the left, on the far right. Next. Next page, like sometimes the legs can cause you have problems. Sometimes you can get blockage of your arm also with no blood flow to your arms also. So that's another concern. One second, put a hold. That's volume down. No. So this patient had upper extremity problems. The innominate arteries, which is in their chest area, was blocked up, and the patient was having a lot of pain in his right upper extremity. So we're able to, and that these patients would present with very low blood pressure on that affected side. So the blood pressure was low, almost absent in the right arm. That was a predicting factor. A CAT scan was done, and it showed blockage of that artery. So again, if you look at the picture on the left, where that blue mark is, you see the blood flow stops right there. It doesn't go beyond that. And we were not able to make a wire go through because we came from the elbow. So we had to go from the neck, the carotid artery, and we eventually were able to make a wire go through it, and we eventually were able to reopen that artery. And you can see where the balloon goes. And we're able to balloon that area, and you can see a stent in the middle. We're able to put a big stent, and the patient did well. You can see a final image. Again, that's endovascular surgery. So another patient had blockage in the left chest. Similarly, we're able to put a balloon and put a stent, and you could see the middle image and the final image on the right where the balloon has resolved the problem. This, because PAD, as I told you, critical ischemia is not only an American problem, it's a universal problem. This is the story of a 57-year-old Nigerian male physician who traveled, who I'd known in the past in Nigeria, worked with in the past. So sometime around December, calls, says, "Oh, I have a problem with my foot." I said, "Well, send me a picture of your foot." He did. When I saw the picture, I'm like, "Oh, that's not looking good." I said, "Well, I'll send you to one of my trusted collaborating physicians, US trained in Nigeria. So deal with your problem." He said, "Oh, no, I want to come to the US." I'm like, "Okay." So he came. So he bought a flight from Lagos, came all the way to Atlanta. From Atlanta, they moved on to West Virginia. I went to the airport to pick him up. And he was 57 years old at that time. He looked like he was 67. He had aged within that short period of his illness. I had a blister in his foot area, around the area of his big toe. Despite wound care measures, that worsened. It was treated with antibiotics. When he arrived, amazingly, his kidney function as part of his workup showed that his kidney function was only 9%. So it was an acute renal failure at that time. So he was walked up aggressively, and luckily for him, due to aggressive treatment when he got here, we were able to help him out. Now, the problem was when he was in Nigeria, was treated with some gentamicin, and gentamicin is an antibiotic that hurt his kidneys. So that was the reason why he had kidney failure. This guy could have died many times over, but he was lucky. Next. So that's the foot when he first presented, and this rapidly got worse. Next. So again, as his white count was over, blood count was over 20,000. It was sick. His diabetic not controlled, hemoglobin A1C was over 11. His low extremity showed normal blood flow by Doppler. Next. But you can see the foot, top of the foot just looks bad. Okay. And just got worse. So eventually he had a partial, what's called transplantosal amputation performed. Half his foot was removed, and same day it was feeling a little better, but then he continued to have worsening pain. The skin got worse, it wasn't healing, and eventually he developed pain, more pain, and heart rate went up. 140s, acute shortness of breath. We thought he had a blocked clot in his lungs. It was diaphoretic, sweating, and his oxygen count was only 42% saturation. And EKG was showing that he had a heart attack. Give me 1 minute, please.
Sorry, Doctor. There's
Right.
a
That was,
mini emergency.
sorry?
There's a mini emergency. Had to be called away.
Yeah. That's the life of a surgeon, life of a doctor, actually. We are used to this. So thank you. Thank you for holding the fort. I was just going to say, this patient, uh, whew, talk of complications after complications.
That's
Uh,
right.
yeah, it's the diabetes is the root of all evils, sometimes in cases. And we've talked about blood sugars, controlling diabetes, and high blood pressure on this platform so many times. These are the reasons why it's important to screen, to know if somebody has diabetes or they have high blood pressure, and to treat it. Usually when somebody have diabetes, they also have high blood pressure. And, wound in the foot or in the leg area is a huge one for diabetic patients that can cause complications. Most of the diabetic patients that we've seen that develop some kind of wound in their legs, if they're not properly taken care of, they're going to end up with amputation. Sometimes it's going to cause death for the patient. So, treating the underlying cause and even before treating, preventing is a huge deal. And diet and exercise does a lot to avert a lot of these chronic problems, you know. So if a patient does not have diabetes at all, if they're able to prevent it when they have those hyperglycemia, which is, high blood sugars, and they're able to prevent it, then they wouldn't have to worry about developing what Dr. Oye was talking about, this ischemia, which is lack of oxygen or decreased oxygen flow to areas of the body, including the legs, as we have seen here. And when they don't have that, then they don't have to worry about it or deal with that complication. So taking care of your underlying problem
Yeah,
is huge.
good.
Welcome back.
Yeah, thank you. Yeah, I just operated on one day. Had some questions.
Before you go on, Dr. Buka
Yeah,
just wrote that diabetic patients must do podiatry visits. She's
yeah,
right. The diabetic patients should see podiatrists who are fit doctors or foot doctors so they
yeah.
can screen them and check them. The floor is yours,
Yeah,
Dr.
so anyway, he
Sorry.
was treated with amputation of his right foot. And like I mentioned, then we did all this testing. He did not have blood clot in his lungs, like a PE, but it was confirmed to have a heart problem. So went ahead and because his pain was too bad in his foot, the foot's getting worse, his white count was elevated. So I just went, and the initial surgery was done by the podiatrist. So I just went ahead and did it, fit it right below the amputation. And the day he had amputation, he was sitting about 2 hours after Falcon went out. He was sitting in bed, playing on his phone. Then subsequently, he had the shortness of breath issues that we went and worked them up. We then eventually got cardiologists involved, and then they did a cardiac cath and found that he had 5 arteries in his heart that were clogged up. He had PCI, percutaneous coronary intervention, had 4 stents put in his heart to restore flow, and his chest pain got better, and finally got better. And he was in the hospital for about maybe 3 weeks, which is usually long for us in the US. Not because he needed to be here, but because he had no insurance traveling from Nigeria. Then he was lucky enough that the caseworker here was able to give an try to get him to get emergency Medicaid, which he thankfully got. So all this care was free. Even got an prosthesis provided free. I mean, most if you and I go to a hospital in America, we're not going to get that free. But he came from Nigeria, didn't pay one penny of tax. Here was he had everything done free for him, which was good in a way. But he should have died or could have died on that long flight from Lagos to Atlanta. with five vessels that's clogged up. He could have died. He could have died between Atlanta and West Virginia. So, I guess his lucky stars, someone was watching out for him, so he survived. And he was able to now do rehab, then had his prosthesis, and eventually stayed in the US for about 2 months before he went back to Nigeria, ambulated with his prosthesis, and gone back to his clinical practice. And so that's the way it happens. So sometimes you need definitive amputation to solve a problem. Okay, our goal is to prevent amputation when we can, but sometimes it's inevitable, like in this case. But again, when he got amputation, definitive amputation, he got better, and his heart got better, and everything got better for him. Next. Again, so this is a portion of the partial foot amputation. Next. All right. So again, he did well. Next. We did control his diabetes, and thankfully his kidney function, which is 9% GFR, glomerular filtration rate, that's 9%. That's really, really low. Should be on dialysis. But we're able to got the renal people involved. They was hydrated. They were able to avoid him going on dialysis, despite the fact they had even contrast for his heart problem. He survived his kidney function. They're back to normal. Did not need to go on dialysis. Next. When is amputation necessary? This is a case of a patient with means to travel out of Nigeria to seek healthcare solutions in the US. Many patients in Nigeria cannot do that. 1.5 to 2 billion US dollars are spent per year for medical tourism. People leaving Nigeria to Europe, to India, to Dubai, or the other parts of the world to get healthcare solutions. We must improve healthcare in developing countries and the infrastructure by training our patients, our staff and patients to reverse the thinking, to have to reverse medical tourism. So that way the monies we spend outside Nigeria can be spent in Nigeria. That way we're able to pay the Nigerian doctors and nurses better, so they don't leave Nigeria to go seek health job opportunities outside the continent. Given the multitude of problems this patient had, he could have died at any point during the spectrum of his care. Okay.
Somebody raised their hands.
Somebody raised their hand.
Yes. Are you
Yes.
done presenting?
Oh, no. I'll answer. Let's keep going. No, I'm
Okay,
not done.
you want her to ask a question? You're gonna meet her, you're gonna meet
she has
her in
a
a
question.
couple of weeks.
No. Go ahead and finish.
Okay.
Okay.
Okay, no worries. Again, take-home message. Chronic limb ischemia or critical limb ischemia is treated with endovascular therapy. And when treated with endovascular therapy, has high technical success rate up to 90%. Low mortality or bad ill effect occurring less than 2%, and complication less than 5%, and 1 to 2 year limb salvage rates can be as great as 80%. So rather than cutting a leg off at 65 to 80% rate without doing anything, you can save a limb 80% of the time, greater than 80% of the time. So that's certainly worth doing it if the patients present early in the course and you have the tools, you have the expertise to provide care. You certainly can save those people's lives and limbs. Again, remember, when you have one has an amputation, it's not the amputation itself that matters. It's the fact that they're going to have an amputation, psychological fact they're going to lose a limb. If they were active before that happened, they'll get depressed. And if they're not really ready to lose a limb, it's a cascade of event. You can sometimes even die from the fact that you get a limb cut off. Next. Conclusion, endovascular therapy has gained popularity and traction for many of our critical limb ischemia patients. We do this routinely, and we do this not only in the US, we also do it in Nigeria. When I travel to Nigeria, I go from Lagos, Ibadan, Abeokuta, anywhere somebody needs help, I go do it, and then they come to Lagos, Bayelsa, whatever. So again, our goal is to improve our awareness so patients know about it, families know about the fact that they have the condition and know where to seek help when they have a problem, seek for solutions. Some advanced cases of failure can be tackled with open intervention. We're not saying that we should only do endovascular intervention. Sometimes endovascular intervention may not solve the problem. Sometimes you may do a little endovascular intervention, a little open surgery, which is called hybrid. Or sometimes it may just best to do open surgery altogether. So again, And endovascular intervention requires a lot of training. It requires a lot of judgment to make the right call. Patient selection, you have to select patient appropriately to get good results. Next. Okay, that's part one of the talk. Part two I can do very quickly, and then we can ask your questions. The evolving future of endovascular surgery in Africa and rural America. This is damn passionate to me because not only am I a vascular surgeon in the U.S., I also practice vascular surgery, trained and registered. I didn't registered. I didn't train in Nigeria, but I registered in Nigeria to practice medicine. So I do practice my craft in Nigeria also. So again, it's been a field or discipline of vascular surgery that's grown massively over the past 35 to 40 years. And the initial resistance by many surgeons to adopt this technology has just, waved this time to the point that they know is a way of the future. Residencies, many fellowships are now the way at the order of the day. And the first, I even know when I did my fellowship in endovascular surgery in 1996, 97. At that time was early on. Now most training programs have that as a requirement. So many of the younger doctors that are trained in vascular surgery, they're not as well trained in open surgery. We have the benefit to be trained in open surgery and in the vascular surgery. So we're at the crossroad. But these younger surgeons may sweat when you have to do open surgery because they're not so much trained in open surgery because they know a lot of endovascular intervention techniques. Next. And little brief history here. Charles Dotter, in 1964, was the very first person to put a balloon in an artery to open it up. And my trainer and a lot of other trainers listed above, my trainer was Dr. Edward B. Dietrich, but other famous doctors in his age group include Dr. Tom Fogarty, who was a medical student when he came up with a balloon catheter. He was a surgical technologist and those types they used to cut people's legs off. So I said, well, what can I do to help the doctors at that time? So he came up with a balloon concept where you could put a balloon in an artery and you inflate the balloon, take a clot out. That's what we'll call a Fogarty catheter. Dr. V, this a respected vascular surgeon in his late 80s, who or the 90s, who still is active in surgery in arena. Dr. White and others. Next. The first heart outpatient cath lab was founded in 1971 by my trainer, Dr. Dietrich, and a very respected, well-trained, respected endovascular cardiac surgeon. And he died in 2017 from brain cancer. We are exposed to a lot of X-rays when we do surgeries, and one of the ill effects is sometimes cancer. Next. Dr. Dietrich trained a lot of people around the world, including Africans, myself included, one or two more Nigerians, and two doctors from Senegal who were given scholarships just to come there to the Heart Institute to train and go, and they went back to Senegal. Next. So that's me. That's my journey from Texas to New York to Arizona, Clarksburg, West Virginia, Beckley now, my special hospital in Nigeria. I'm a freelance global endovascular surgeon. So whenever somebody wants to is about to lose a limb, they call me. If I'm available to go, I'll go. If I can't go, I can make ways to see if I can get my collaborating doctors around the region to help them out. So that's the reason why I say it's important. If you have family members, friends, or somebody that says they have a leg problem, you can let us know. If it depends where they are, it doesn't matter where they are in the world, we can find somebody to address their problem so they don't lose their limbs. Next. What's the future of endovascular surgery? It's an evolving science area, and it's really evolving to a large extent in medical disadvantaged communities. It's a major challenge because we don't have the technology available, we don't have the staff necessary, and the equipment to run some of this program. Again, I was fortunate to come to West Virginia in '97, and came to, even as deemed a rural area, the hospitals were able to afford the machinery that you need to perform the surgery. So I took advantage of that, and I was able to do that. So right now in West Virginia, we have all our major hospitals here can do endovascular surgery, which is a good thing. Cardiovascular and vascular disease profile in Africa and rural America is very similar to those in Africa. And again, the only difference is end stage patients present with end stage disease problem. Again, due to lack of funds in Nigeria, all African countries, they go to their imam, they go to their pastors. After everything exhausted, and they come to the doctor, and then it's too late. The cost of intervention can sometimes be exorbitant for the average African whose yearly per capita income may be only $360 a year. How can you afford some surgery, which in the US may cost anywhere from 60, 80, 100,000 US dollars? It's not feasible. Again, supplemental governmental assistance, such as Medicare, Medicaid equivalents, non-exist in some African countries. So that's a problem. Next. So our goal is to make this endovascular experience, the future in Africa, more accessible, more affordable. And that's the reason why I travel to Nigeria every 2 months or so, to ensure that we continue to build on the endovascular presence in Nigeria, collaborating with Nigerian doctors, train our Nigerian doctors, and create an aura of awareness. And every year, every October, we have the Endovascular Conference for Africa and Rural America, which we just completed this past October, where we have talks by prominent doctors and a host of medical students present endovascular cases to increase our awareness of the condition. And that has taken hold. We've been doing that at the endovascular program, training program, the conference, 8 years in a row. Next year will be the 9th year. The cost of setting up an endovascular center in a hospital in these communities may not be feasible. It's just expensive. Even the U.S. large urban communities are having financial losses from providing these treatment options for complex cardiovascular and vascular conditions. So what are the challenges in Africa and Nigeria particularly? Availability of ready power supply to run a cath lab. You need a cath lab or a CR machine to do these procedures. Okay, corrupt governmental regulations. Our government is corrupt. I don't have to tell you that. Lack of adequately trained endovascular surgeons. Even in the US, we don't have enough endovascular trained surgeons. So now if we go to Nigeria, which population is 232 million, if the US is struggling at 350 million, we still have a problem in Nigeria. So again, we have to think outside the box to make it feasible in the context of Africa. We have to train surgeons who are not endovascular surgeons who have interest can be trained to kind of do certain things that will at least help patients. The lack of equipment and consumables such as balloons, stents, wires, expensive stuff can be extremely problematic in the US because the hospitals were very wasteful in the US. We'll open a package of something, we don't use it, just throw it away. That's something that will save someone's leg or life in Africa. So it's a problem. Next. So how do we change the narrative? First, we have to create regional centers of endovascular excellence. Now, I can tell you from our work in Nigeria, I did in National Hospital Abuja in 2017, an aneurysm surgery, which had never been done in the continent, was a special stent endovascular procedure in 2017, April 7th at that time. And this is a tragedy of our country, where 1,000-bed hospital, National Hospital Abuja, you go in, you say you're going to do an operation, you're lining everything up, say we're going to start at 8 o'clock, and the technician who's supposed to run the machine shows up at 9:30. How can you do that? And not only does he show up late, he doesn't know what he's doing. Worthless. Again, you have 7, 8 machines sitting on the hallway, only one is working. So those are challenges that we have. So we have to create centers. I would propose center in Lagos, center maybe in one of the western states, one in Niger Delta, it could be Warri, Bayelsa, Port Harcourt, that area, access, one in Abuja area. So that way, if somebody has an ischemic leg, and in one of those zones, they can easily get to that area and be seen, be treated by a trusted healthcare professional. The concept that we've developed in West Virginia since I came in 97 to now is the concept of an office-based lab. The concept is unique. So many years ago, and now we can still do surgery in the operating room. We can do surgery in a cath lab to improve circulation for people's legs and whatever. But now that concept has evolved to the point where you could actually have a room in the office that has your equipment. Literally, you can do that operation in that room. The patients get treated. They go home the same day. They don't hang around like in Nigeria, say taking a drip for 3 weeks, 4 weeks, 5 weeks. No, they get treated, they go home the same day. The person that treated in Lagos in an office-based lab, a physician came in, was treated the same day. He went to the hotel that evening, next day. He went home back to Ibadan. Another person that came from Abeokuta came into Lagos, was walking around for 2 years with a wound in his leg that wasn't healing. We did in the office-based lab, did a fem bypass, groin bypass, angioplasty. We watched him over. Watched him overnight. He went home next day. It can be done again, and you decrease the cost tremendously for the patient. And that's when I talk about affordability. That's one way to do it. If a patient in Lagos wants to have a leg surgery done, and I take them to lawsuit, just walking into lawsuit cath lab, and not raising a finger, they have to pay 1.8 million naira just to enter the cath lab room. Imagine now I have to do the surgery. I have to put wires, balloon catheters. The cost will be too exorbitant. And that's the benefit of the office-based lab concept, where now that $1.8 million naira goes away because in office-based lab setting, we only treat them for what they can afford and be done. So we're able to treat a lot of people that way. And like I stated before, we have education conferences for training and awareness. Also using social media, television, radio, newspaper campaigns to increase awareness for PAD and all the other forms of vascular surgery is essential. More importantly, we know our resources in Africa, and it's a shame that we have our raw material in Africa. People from the US and Europe come in, China, India come in, they take our resources, then build a wires, build a stand in their countries, and turn around and want to sell this resource back to us at a very high price. Imagine if our schools of technology, biomedical departments can start using our raw material and start making these items ourselves. Then the cost will go down. Again, we can't just be all about theory. We have to always, be more practical, be able to do those things. Our vocational schools, we can use raw materials to build our own stands, by our own wires, and our own technology so we can take care of these patients. Okay. All right, so how can we change the narrative again? Government has to help. Prevention is better than cure, it's said. So if we prevent these problems by doing the necessary examinations we need for patients, we can make the healthcare where they need more invasive surgery later less. So again, they say prevention is better than cure. Improving work conditions. So our healthcare providers, physicians, and healthcare nurses and technologists don't leave the country, so they stay because they're working. They have to be paid for well for what they do, so they don't want to. They can stay within the continent. In reversing medical tourism is against a big thing. If we're paying 1.5 to 2 billion US dollars a year, billion would it be, to leave Nigeria to go to all these other countries to seek health care, it's a problem. If we leave that money in Nigeria, maybe we'll be able to pay our doctors and nurses better. Develop a practical training program for future persons interested in endovascular surgery through meaningful collaboration with established outfits in the US, such as the International Society of Endovascular Specialists, the Society of Vascular Surgery, and American College of Surgeons. In conclusion, I submit that the future of endovascular surgery remains clouded. The unveiling of the cloud will depend on meaningful collaboration with reliable international endovascular specialists, enhanced local educational training program via virtual and in-person platforms, which in reversal of medical tourism, better governmental contribution in terms of subsidy, improved local biomedical research, and development university and vocational schools. And we do a lot of that virtual stuff because of the collaborations over the years we've done. We get a doctor send me images from Nigeria, I review them and say, well, we need to do that, and I can help them through the process. So that's one of the ways we've tried to improve the endovascular presence in Nigeria. Thank you so much.
Wow. Thank you so much, Dr. Oye. I
Indeed.
appreciate you. We appreciate you. We know all you do. The last time we did medical missions in Nigeria, you were there on ground. I have had the opportunity to see what you do, and we can't wait for what you're going to do in Abeokuta. Madam VP, Madam CEO, is coming. We're partnering with NAPAC to do this next round, and she's going to be on ground. She's
Okay.
one of our founders at NAPAC, and she has remained a pillar, a mother for us. I call her Mama, Mama NAPAC. Madam VP, kindly ask your question. You guys will meet, personally, in person. You will meet in Abeokuta
Yeah.
next round.
Thank you, Dr. O,
You're
Commissioner.
welcome.
Commissioner O. Yes. So, Dr. Herbert,
Yep.
thank you so much for your eloquent presentation. We appreciate you and all the work you're doing. Sitting on this side of the fence, we have observed a lot of things, even though I don't have exact number of physicians that are Nigerians, but in my own wild guess, I would think that in the US alone, the medical data would be probably 40% Nigerians. So I'm saying that to say we do not lack the talent that is needed. What I think we are still challenged with is the collaboration that is required. In your summation, you said reversal of medical mission. With due respect, medical tourism.
Reverse medical tourism.
With due respect, sir, I don't think that is the problem. That is not the problem. We should not reverse it, but it needs to be restructured. So one of the questions I want to ask, humbly ask you, sir, is, do we have a central registry that everybody coming into Nigeria to do medical mission registers? Do we have that currently?
Okay, let me explain this before he answers. Those are two different things.
I understand. It's a leading question.
No, I know. Medical missions is missions that we do to basically screen and merge people to care. So say we're on medical missions and we see somebody with diabetic foot or foot like we just saw in those pictures, and Dr. Oye is on ground. Even if he's not on ground, I'll call him and he's going to link us to peers. We don't have many in Nigeria. How many do we have in Nigeria? Like 3 people who can do this, Dr. Oye?
Well, that probably, but the problem again is multicentric. I have endovascular surgeons trained like me who are Nigerians who would never go to Nigeria, no matter how well you convince them. Okay, so that's because they probably live there, well, worked up, trained in Nigeria, and had bad experience in Nigeria and don't want to ever see the shores of Nigeria. Okay. You have somebody like me who finished high school and came to the US, and I did everything here. And I have a nostalgia to go back to Nigeria, and so it's my motivation is different so our prior experience will make a difference. But we have enough. We don't have enough, yes, but the problem, the solution is not the number. The solution is collaboration. We have some persons who are trained cardiac surgeons that I work with in Nigeria. They're not endovascular surgeons, but they have interest in learning endovascular surgery. They have some skill sets already. So you cannot go train somebody and say, well, you got to go do 5 years of general surgery, 2 years of vascular surgery, or 7 years of vascular surgery and become an endovascular surgeon. You can do many fellowship training for those people who are interested, and they can learn some of the skill sets, so they can at least be valuable to their patients. So that's
understood.
The direction.
I don't mean to interrupt you.
Wait, 1 minute, ma. What I was saying is that if we need the help, even if you're not on ground, and thank God you're on ground most of the time, I'm there. I can call you, you can call one of your peers. You and Dr. What's his name? You went to see Papa Obasanjo.
Sanusi,
Sanusi.
Dr.
And
Sanusi.
yeah, somebody like that you can call him. So
Yeah.
that's medical missions. But reverse medical tourism is a totally different thing. This is
Okay.
what reverse medical tourism is. We have medical tourism, a lot of it in Nigeria. The man who had that number 5 patient who needed vascular surgery intervention, but decided not to do it in Nigeria, even though it was offered to him, decided to fly over to the US, had to go through Atlanta before then flying to Virginia. That long trip was, look, God saved his life. He ended up having a heart attack, having all of those. That is medical tourism. People live in Nigeria or Africa generally to go overseas or to come overseas for their medical care. Now, what we're talking about is if the resources are in Nigeria, if collaboration is done properly, Dr. Oye is ready to train, and we're already working on that also now. Is ready to train doctors who are interested in Nigeria. If that exists, instead of people traveling to overseas, the US, the UK, to get care, they will get it in Nigeria. And guess what? Other African countries will be traveling to Nigeria. We have seen that is reverse medical tourism. When
Got
they
it.
are traveling out for medical care, we have
Okay.
seen it happen. We've seen it in oncology at Luth. People are coming from the UK, from the US, from African countries to get cancer treatment. We have seen reverse medical tourism, even with endovascular surgery. I don't want to go into the details of it, but we've seen people travel from overseas to Nigeria to get it done because it's cheaper. When we
Yeah.
can
Yep.
do it in
Yeah,
Nigeria,
along those lines, when we talk about reverse medical tourism, if you're spending 1.5 to 2 billion US dollars to
billion.
a billion with a B to leave the Nigerians actually spend that money. They're paying all these other countries, you know, to experts in this country to treat them. If that money remains in Nigeria, it'll do better for the Nigerian economy, number one. Number two, I give a classic case. I'm like right in Beckley, West Virginia, and I'm passing by, and the nurse that I used to work with a few years back said, "Oh, I'll be having hysterectomy." I'm like, "Hysterectomy?" I'm like, "What happened?" "Oh, I have a fibroid problem." Okay, I'm like, "Okay." They're about to do a hysterectomy on me. I'm like, "Are you sure?" I'm like, "You're 39 years old. Do you want to consider a myomectomy in Nigeria? Because Nigerian trained doctors do a better job with myomectomies." That said, they're better at myomectomy than US trained doctors. If you go to US trained doctor, they'll take your uterus away. You know, if you don't want to lose your uterus and you feel strongly that you don't need to lose your uterus, then go to Nigeria. You will get your uterus retained, myomectomy. And that's what happened. I advised her. She traveled from here, went to Bielsa Special Hospital, had a myomectomy done, and did not lose a uterus. They were about to take a uterus complete hysterectomy right here in the USA. She got remarried. And so that's reverse medical tourism, where somebody leaves the United States and goes to Nigeria or other African country to have the care. That's reverse. And people from Nigeria are not leaving the shores of Nigeria, staying, keeping their money in the shores of Nigeria. So we're able now to pay our doctors and nurses better. And that's the essence of reverse medical tourism.
Yeah, that's
Yes.
reverse
Okay.
medical
Thank
tourism.
you, both of you.
Now,
My Can I wrap up my
yeah,
Sure.
now you can ask your question. I wanted to be sure you understand the
No, you
difference.
did mention
Yes.
registry, though. You did mention registry. Some of we have some registry in Nigeria. The Nigerian Cardiac Society does have a registry, but I'm not sure we have a registry of non. We don't have a pure registry of people coming from outside Nigeria coming in. We don't have that yet. That's something that I think could be embodied in as we
Thank
improve our
you.
collaborative process.
Thank
There
you.
is no
And
such registry. And you know what? It would deter a lot and it would complicate things.
well,
In
let
the
me let
past,
me let me
yeah,
explain where I'm going. And I am excited about Dr. Oye's passion because and he's speaking like a true Nigerian, otherwise you will not even be there. And you're talking about impacting the entire health ecosystem, which is what I would want because I have loved ones in there. It's not even just restricted to your specialization or even Dr. O's, or I mean, my God, she treats cases that people don't even want to acknowledge exist in Nigeria, you know, HIV and all of those things. But what I'm saying is, one of the mantras that I live by is accepting something that is closer to what you want to get. We need to be able to leverage all this fragmented medical mission in some way, in a way that the data collection will work for all of us. And here's what I mean. The people going to do medical mission, they're spending their own money. They're spending their own time. They don't get paid when they abandon their job here. However, these things are still done independently. So what I'm hoping, or my intent for suggesting a registry, it should not be anything that creates a barrier to the work you're going to do. We're in the digital age. It should just be a simple going in there, registering to say, hey, I'm going to do whatever in so place. And for you guys to be able to safely share the data, because it is not until then, when we have a structured sense of collaboration or form of collaboration, that we can truly start to impact the outcomes that we're all looking for. Whether it's otherwise, right now we're still isolated, in my opinion, because it's not just Dr. O. Many people. I've even gone on one medical mission before, organized by AMPA, you know. But what we're looking for is to be able to have we want our impact to pack a sucker punch where it is felt. And it's going to take some time, but we need to start sharing the resources that we have. That is one of those aspects. Many other aspects are there. Dr. O has our own expertise, you do, and other people. But at the end of the day, what I'm hoping that we together create a sustainable system. You're thinking of or maybe you're already doing it. I don't know if you said you're already doing it, like a train the trainer module. Dr. O, I told her once, if she was my teacher, I would be a medical doctor, because she's a good teacher, you know, and so many people like that. There's the trainer pipeline. I don't even think that we lack people who want to be in the medical system, but how do we start to harmonize all of these different fragments of support that we have? That is where I'm going with this. And we don't need to be in 4 different places at once. If we choose to start in Warri, let's perfect Warri before we start franchising to Lagos and then the North. It's easier to travel internally. If we have the specialization station in Warri, everybody will travel to Warri, because we split here by trying to say, oh, we have to have one in Lagos, have another branch in this and this. The same doctor doing the same thing. Anyway, it's just a suggestion to all the great things that you're already doing. With all love for you, Dr. Oye, thank you for representing us. However, my suggestion is, how do we start to identify all the different needs in this entire spectrum, and how do we start to use whatever is available right now? How do we start to use it together to make it make sense? Thank you.
Great. Thank you for the question. Quick comment on that. I can tell you from what I've been doing over the years. Number one, we have the biospecialist hospital, which is a 60-bed hospital that is full-fledged, can work. If I go to do an operation at that hospital, it'll feel like I'm in the United States. I have my operating room, have my cath lab, everything's there. Then over the years, again, that's why I say government sometimes doesn't work for its people. The government does not contribute much to the success of that hospital. It's right on the campus of the government house. The governor drives his motorcade through that every day, but never sits down with the people that run the hospital and say, what are the challenges? How can we make this hospital better? Never do that. So we spend a lot of money trying to make it work for the people, because we don't want people to die. So that's one. So what I've done, because I hear you what you're saying. I've been there, done that. I go to conferences and give talks to Nigerian people, and when it comes to implementation, no person wants to implement. And I'm a surgeon, if I want something done, I get it done. I don't have time to fool around people. So I started a program where I said, well, we're going to have a pilot program. We have the hospital that's in Bielsa. We're going to have a pilot program to make the most impact in Lagos. So I went to all these hospitals in Lagos, and I saw that they were just fleecing the patients. Patients go to the government hospital. You want to charge 1.8 million naira just to enter the cath lab alone? Who does that? So, and I'm the one doing the surgery almost for free for the patient. Trying to pay 1.8 million, that doesn't make any sense. How can the patient afford that? So that's when the concept of what I've been doing in the United States, which in the United States, our insurance companies love us to do surgery on an outpatient basis because number one, safety and money, and patients go home the same day. So that concept has been perfected here in West Virginia by me in the past 27, 28 years. So I took that concept of Nigeria to Lagos and have that office-based lab. In that setting, I'm able to provide care, same care they would have in the United States, in my complex operating room in the United States, right there in the office-based lab, where the cost goes down drastically down. And if they can afford to pay something, fine. If they cannot afford to pay something, we don't send them, say, go lose your leg or go live your life. No, we take care of them. That's the concept we have. The concept we have in Bielsa, if somebody walks to Bielsa Special Hospital today, whether or not they can afford to pay, not pay, unlike Nigeria, if you don't pay, we're not going to treat you. They get treated. Okay. So that's the concept we've had has worked well. And that pilot program is doing well in Lagos to the extent that we want to get to the point that once that's fully functional and going the way, then like we talked about regional centers, because I collaborate with a lot of doctors, Port Harcourt, Bielsa or Warri or whatever I built with that. But again, your main hub, you must have a main hub. But when patients are, say, in Abuja or say Warri, you don't want them going all the way to Lagos when having ischemic legs emergency. You must have a satellite that's closer to them that can handle immediately, stabilize them before you take them to where. So we have that concept in place that's working well. So I get calls every time from Abuja, Lagos, Port Harcourt, but ultimately Lagos is our main hub for the endovascular office-based lab at this time. So that number one, the cost is down. If I do an endovascular case at one of the major hospitals in Nigeria, they may want to charge the person 15 million US and 10 to 15 million naira for surgery that I could do. But that surgery done in the OBL office-based lab, that person may end up paying like $1 million, $1.5 million. That's a big difference. What the cost of just entering a cath lab at last, which the government hospital is 1.8, they have the surgery done in the office-based lab for less than that. So that's the concept. And that's one way we're able to provide care for a lot of people and to have a foundation in the US. When they can't afford care, we never turn them down. We're able to contribute to their care that way.
Thank you
Who is
so
that
much.
good-looking gentleman sitting next to you? He's so I hope we didn't scare him with
This
all
my
of this.
medical
No,
student.
no. It's
Ah.
it's
This
a
is the
third year
future.
medical student. He
This
was
is the future of medicine. So I train all these young doctors. He's from Nigeria. I train all these medical doctors, young doctors over the past since 1997. He's trained in vascular surgery. I can bet you I can take him to Nigeria. It'll function better than most Nigerian trained doctors to identify vascular conditions and offer proper solutions than most well-trained doctors in Nigeria. That's the benefit. Not only do I train them in the US, when I go to Nigeria, I do the same training. So training is the way to go.
Thank you so much. And Dr. Oye, thank you. Because in case you missed it, Dr. Oye goes to Nigeria like every 6 weeks. He has a family. His children are doctors, by the way, too. And I have been to the lab. I see what happens there. Can you imagine removing a clot and everything and patient is out in 3 hours? That's what he does. Madam CEO, what you suggest is excellent, but guess what? Like he's been there, done that. I've been there, done that. Dr. Ezugu is on right now with HTPTC. We're still going through that the government is not sending people to just approve this place for primary care. So how do you see patients? And staff is being paid and they cannot see patients. When you start going through database government, take it hands down, shut all of us down then. Because the bureaucracies are just impossible right now. Things need to change. So what we do, go there, focus on the people and get the needful done. just like Dr. Oye is doing. Somebody needs help, meet their need. You're waiting for government data and all of that. They frustrated me that in 2000 and I think it was 2000 and from 2009, 2010, I said I wasn't ever going back to Nigeria to go give back again. My father talked me, counseled me, talked me into coming back. That was why I started the missions in Kenya and in Ghana eventually, where you are accepted. The bureaucracies are huge. We want to do the best we can for our people. I think, unless that changes, I don't know.
Nigeria is a tough place. I mean, we make the simple thing difficult, and that's what's frustrating.
Yeah. But thank you so much. We get it. We would love what you said. It's just that we need to talk more about it. Auntie Tower, kindly unmute. Thank you, ma'am.
Yeah. Good evening, Dr. Oye.
We don't
Good
see
evening.
your face, ma.
You can't see my face.
That's okay.
And where have you been, Auntie Tawa? We did not see you for the past, you're fine.
For the past 10 years.
I had a young grandbaby, and I've been going back and forth in Texas. So that's why you didn't see me.
So let's see your face, ma.
Oh, my face? You don't want to see you'll see my face next week.
Okay, ma. Okay, ma.
That's
Okay.
fine.
Good evening, everyone.
Good
My
evening.
question is not really a question, is number one, I'm thinking instead of waiting till the patient gets to the end stage of like PAD, what
Yeah.
are the prevention? What can we do? What is the type of education we can give to our people that they won't go to that situation? Because
Sure.
there's a girl now, she's 40-year-old. She was going to go to Thailand. Her sister left London to go to Thailand. She left Nigeria to go to Thailand. Her sister got there, she didn't come. She was worried. She called the mom, and the mom said, yes, I personally dropped her at the airport. Guess what? She had whatever she had in the plane, and they have to intubate her.
Oh,
Till now, it's been like 3 weeks now. She's not coming back. They flew her back to London. She was born in London, though she lived in Nigeria. In London, I've been trying everything. They put her on vent, trying to see whether she can come back. She's not coming back. So they said they are going to take her off the vent. But I was just thinking, this is a lively girl. Maybe while she was traveling, she had a blood clot on the legs, because our people don't move around when they're in the plane. They just
Sure.
sit in one spot.
Right.
They develop all this clot over
Right.
there. So what do we do in educating them so that they can know what to do? Maybe they have to wear tedos or do something to prevent all this kind of clot.
Right. Yeah, the first and foremost, you hit the key point. The key is we need to create awareness. Awareness is the key, and that's the reason why I go to Nigeria all the time. Every year we do our vascular conference to create awareness, not only for the patients, for the public, for physicians, healthcare workers, so they know. Okay. Awareness is the key. Again, nowadays you can take your phone and dial PAD, and you can have all the information about PAD. Again, and unfortunately, the person that was traveling most likely had a blood clot, if one had to surmise, what will make one have a certain problem in the flight, such as that is either a major blood clot in the lungs or a heart attack. So those are more common answers. So hopefully, I hope they can figure that out. But again, awareness is important. And nowadays we have technology that what I just talked to you about, the endovascular surgery. If somebody has a blood clot in the lungs that could jeopardize their life, we can easily put wires, catheters into the lungs and stump the clot out. And somebody who would be on a ventilator would be off the ventilator in like 30 minutes. So those are the benefits of endovascular surgery. Again, that comes with awareness, that comes with training. You have to train the people to have the skill sets to do this. It's not easy stuff. Again, it takes judgment and time. So training of our healthcare providers, creating awareness for our patients and their families is the way to go.
Okay, what's our future with AI? Do we have like a robotic arm that can go there and retrieve the
Well,
blood and all those stuff?
yeah. AI is the way of the future, and physicians today are really uh, if you're a physician today or a healthcare worker, even non-physician, if you don't embrace AI, you will be in serious trouble. AI is really great. In endovascular surgery, we're embracing AI also. AI is more common in cardiac surgery and urology surgery, like we do prostate surgery, robotic surgery, and prostate surgery and general surgery. Vascular surgery, it's coming in not fully there yet, but AI is the way to go. AI is just the way of the future, yeah. But again, we do have minimally invasive surgical techniques, which is what I do in the vascular surgery, and we do have a robotic arm, not for vascular surgery per se, for non others for other surgical specialties that with AI capability down the road will make life easier for both the patients and the doctors.
Thank you very much. I appreciate
Indeed.
that.
Indeed.
Thank you, ma'am. Dr. Zugu, kindly unmute.
Yeah, Captain Oye,
Welcome.
Good evening,
much.
sir. Yes, sir. How are you?
Thank you so much for
You
what
both
you
still
do.
at work. That's what I said. You surgeon.
Well, you see,
Cardiac surgery.
Oye is still wearing his lead jacket. His lead.
I
I did
am.
not want to
Yeah.
write
No,
that ticket
you don't
today, Dr.
understand.
Zugu.
No, Dr. Zugu. Dr. Zugu. He was supposed to start talk and he was talking the OR today. And then in the middle of conversation, he had an emergency. He had to leave and then come.
That's the
So
life.
yeah, that's why he
That's
still has
yep,
his lead jacket on. It's right from the OR to the
yep.
seat.
That's the life of when you hear cardiovascular. That's your life. you know, Oye, this is actually a ministry for you.
Thank you.
And so nobody can really stop you from doing it, even if they don't pay you a dime. It's something that's a core, and we empathize that. And even though you feel it's challenging, we pray that God will continue to make it easier for you, because there's a lot of political challenges introduced. It's not an issue of not even having people who have the talent, or the youth who want to learn, or people who want to do it and do it right, or that the pathology is not there, or that the preventive measures are not there, or that we don't have the money to do what we need to do. It is that the will of the people in power is not there. And even some of our colleagues who are in position think that they know more than everybody else, even though they cannot do the basic things. They use their power as a bourgeoisie to block things from happening, you know? So, and you actually have a much bigger reach into the political atmosphere and people than many other places have. And you can imagine, if you're not there, how can this program continue? And I really commend your ability to bring the young ones, because that's the only hope we have, to really begin to educate them in that pipeline mentality of doing what's right for that country, and how they can take the talent back there, and to understand that you can leverage your life here and there like that. You can live here, go there, like you can fly, just go there, do stuff and come back and use technology. We're going to get to a stage where you're going to be here in Virginia, and by robotics, really run that surgery in Nigeria for this young man sitting next to you, and guiding him through that process. And so we have to really always look for ways that we can go over this mentality of people who are currently in positions there that are blocking these ways. And so I commend that. And if there are ways we can help make these youth and bring them here for summer, whatever camp or whatever training we can do, let's do that, because that's our only hope. Thank you.
Thank you. Yeah. Yeah. I've noticed in the Nigerian context, like I said, I started my campaign in 2000 and crystallized in 2013. I've been going to Nigeria since 2013, every 6 to 8 weeks apart. Since then, COVID time came and I went during COVID time just twice that year per year. But the key is, I have come to the point where I don't trust government. I have no interest in government. Everything that we need to make work in Nigeria has to be private venture driven. That's the only way you need to hire and fire. If you get a government worker, they don't want to work, want to get paid. So then that's why we've been able to succeed to this extent. We've been able to make it a totally private venture. The venture in Lagos is totally private venture, no government involved. And when I go to do cases at last week, a government location, I go there, do what I have to do, I leave. But it just hurts that they charge this patient so much money and they're not providing a single needle, a single IV. I'm providing everything, do it for a fee for the patient, then charge that patient 1.8 million. It makes no sense. So that's the way to go. But your point's well taken. And I know in prostate surgery, you can do, I think the first case with robotic surgery, the fellow was in some place in China or somewhere and did surgery in Italy or something. So yeah, we'll get to that point where with AI assistance, we're able to do remote surgery. And what I'm doing lately or currently is I train the doctors on the other side. And if they have to do a case, I can virtually walk them through the process if they need it. So that's working. But they keep the complex cases together. So when I go help them do what I got to do. So that's the way it works. Center for now.
Excellent. Great job, man. Great job.
Thank
Thank
you
you.
so much.
Mhm.
Excellent. Thank you.
Mhm.
Dr. Buka, kindly unmute.
Yeah,
Oh, great. You ready?
yeah, with this phone, I just don't always find the button to raise
All
my
right.
hand.
I
But
got
thank you,
you.
Dr.
I
Oye.
got
That
you.
was so interesting.
Oh, by the
And
way, Dr. Oye, Dr. Izugu, Madam VP, and everyone else on the platform, actually, Dr. Buka is Nigerian. She's originally Caribbean, but she went to medical school in Lagos, Medilag.
mm,
She knows Mushin and Agege and all of that way more than me. And tells me how to navigate.
yeah,
Hi, Dr.
but,
Boka.
She's
yeah,
an
I'm an
anesthesiologist.
anesthesiologist,
Yeah.
retired, but vascular was my claim to fame. I just love doing the fem pop. But while I listened to this, and I was a little late, my nephew was here. I have a cousin now, an in-law in hospital in New Jersey, who is diabetic, and he picked on his foot, and the nail came off, but the fourth toe got infected. I went down, so he lost that toe, he lost the little toe, and now I think the podiatrist, they're still nibbling. I don't know if it's a fem pop or fem tip. He had a bypass surgery, and now they took off tomorrow. They're taking off the toes just at the joint because they said it can't fit into the prosthesis. So you would eventually lose all. But my lesson today, and they did have some endovascular thing, but I wasn't privy to the results. But my lesson today is to let diabetics know that they should go to the podiatrist and don't pick on their nails. And when I looked at the guy from Nigeria, I mean, it just came back to me. I'm glad you saved him at least with a fem pop. I mean, sorry, with an amputation.
Right.
Yeah. But
Yeah.
diabetics need to go to the podiatrist and they need to stop cutting their nails. I am a diabetic too. And I'm on insulin, but I do my best. I don't walk without shoes. But I'm so impressed with these young people like you. You've taken away all the fem pop from me. How would I survive it with you people now? Because you're
Well,
just
you can still survive. What we do, we still provide, you're retired but not tired, of course.
no.
You can come with us, then you provide anesthesia when we do some cases in Nigeria.
I'm
Yes.
thinking
And
about
actually,
it
she just came back from a medical missions with Dr.
in
Jago,
Uganda. Mhm.
Dr.
Yeah,
BC
good.
Jago. And
Yeah, but
yes,
yeah,
please, I'm going to team you up with Dr. Oye because you can provide anesthesia.
Mhm.
You know,
Yeah,
I
yeah,
mean,
they will
these
be in.
hospitals.
And those patients are so sick. It
Yes.
is
yeah.
funny. Mhm.
Yeah, vascular patients are quite sick. Again,
Mhm.
unfortunately, that for diabetics, it's important that they have the A1C under better control. You'll be
Mhm.
amazed how diabetics A1C is 11, 14. You have a little injury, it may not heal. You may end up losing a limb. It's important for a diabetic that every day, before they go to bed, they check their feet because you
Mhm.
could be diabetic, go to bed fine tonight, tomorrow you have an overwhelming problem that may require a major amputation. It can occur in diabetics. So again, once they have a problem, it's important that the control diabetes, important that they do an ultrasound ABI, and important they do a CT angiogram early on in the process so they can find out what the problems are. That's when endovascular surgery will be of benefit to them. Then that will prevent the fem-pop bypass. Nowadays, we're doing less and less fem-pop bypasses because we have technologies that would prevent us from doing those. That can do balloon angioplasty, we can do stenting, we can do intravascular lithotripsy. Those are the way we can do endarterectomy. Those are things that will prevent us from doing bypasses. More bypass is not foolproof. If you do a fem-pop bypass, like you mentioned, the lifespan is 5 to 7 years for fem-pop bypass. It'll go down. If they're smokers, it'll be less than that. And most of our patients in West Virginia smoke. So you know they're going to have a problem. So that being said, my practice now is doing minimally invasive intervention. We're doing all this fancy stuff to prevent them from getting a bypass. Bypass is last resort. So that has worked well for us. And that's what we introduced in Nigeria. When I go to Nigeria right now, I already have 2 cases already lined up in Port Harcourt when I go in. Somebody that needs surgery, the doctors dabbled in already, couldn't fix it. So when I go there, I'll see what I can do endovascular to kind of help the person out. So those are, again, it takes training, awareness. For diabetics, extremely important. What's common between Nigeria or Africans and the US is diabetes and hypertension. Those are 2 things. Those 2 risk factors are common because we don't smoke as much in Nigeria, but we have such as bad disease profile like in America. So that tells you the smoking is not what's causing our problem, is the diabetes and uncontrolled hypertension. You have somebody that just sit down and have a conversation with you and their blood pressure is 250 over 150. And then maybe a week later, hey, Uncle Joe just got a stroke. Okay. So again, we need to be realistic. And what Madam VP had mentioned, a registry. It's a great idea. Don't have a problem with that. Again, we have to start from the basics. Prevention is better than cure. We need to have a way, if we're going to do certain things, we can take hypertension, for example. Put blood pressure machines on the marketplaces. Everywhere people can go and check your blood pressure. If your blood pressure is high, you go into registry. So you will direct somebody to keep your blood pressure under better control. Prevents you getting a stroke. Prevents you getting a heart attack. Prevents you from getting a PAD. So those are things that we can, as public service situations, help. That's where government could be helpful, but our governments are not. So again, we can't wait on government to help us. If we do, we're not going to have a good outcome.
Yeah, let me just say one thing. My nephew was here with me. He was telling me that he was given medicine for high blood pressure and he hid it until he found out that his wife, when she came to me, her blood pressure was high. And I said, no, this can't work. The diastolic was about 120. He was telling me after he heard that, he said, oh, my child will be left without a parent. So he ran right away and started taking his medication. And he's continuing. Yeah. So I think sometimes we have to drive the fear of God in these patients in third world because they do not. My cousin called me. My blood sugar is just a little high, 250. Fasting. I said, what's your A1C? He never called me back. So somebody was telling me, I said, she is a diabetic. She coming here. I would take cinnamon. They have this denial. I read the riot act to them. I read it like, no, I take insulin. I walk with my medicine. I take all of this, so many per day. And I've been a diabetic for over 30 years.
Right.
So, but the doctors must, and just in Guyana, they're sitting with you and you take it, they're looking at you with a diastolic of 120 and so they're going to work.
That's right. Right. Yeah.
Yes.
And they get a stroke. And when I go to Nigeria, every time I go, at least 2 persons in the hospital would have a stroke. 2. And we're talking people from age of 30 and above. It's unfortunate. Again, that we can control that, prevent that by if you can control the blood pressure alone, you can prevent you can prevent strokes, heart attacks, PAD, kidney failure, just from controlling blood pressure. So if we had to take and if we add diabetes control, we may have PAD under good control. So that's
add congestive heart failure and blindness to that.
Sure.
Train them.
Thank you, Dr. O.
Thank you so much. Attorney Richard Williams said, excellent presentation, very informative. Thank you so much, Dr. Oye.
Thank
And
you.
I don't know who Galaxy A03 is. It'll be great for you to say who you are, your name, so we know you. But this person is asking, said, Nigeria has a medical council. How helpful have they been on these proposals, and have they been approached at all? And then the person added, please throw your questions to the platform for any ideas people may have. Meanwhile, we will investigate how best to approach the Nigerian Medical Council. That the person is of the opinion that Nigerian doctors in diaspora should be represented on the NMA board. That will give them a voice that cannot be silenced. And I 100% agree. Galaxy A03, let's know who you are and let's follow up. We discussed what the issues are, and that's the purpose of discussing issues so that they can be resolved. But we are ready to collaborate. We're ready. We are working already. Not that we are ready to work. We are. Dr. Zugu, kindly unmute.
Yeah, so that suggestion about representation is extremely very important. But I will underscore that in such representation, it is extremely very important that we take politics out of it. People like Dr. Oye, who is doing something there, should be part of that representation. Not some organization that have orders, some whatever, then select someone and say, go represent. Use people who are already working there, have been going through the difficulties, understanding the challenges, be part of that discussion, but not politics. Thank you.
I get you when you said some organization, and that is true. These organizations, a whole organization, raised thousands of dollars, thousands, and they go and they look at what they do, and you're wondering what? And we will go as individuals and bulldoze, do cataract surgeries, pap smears, vision and hearing, and dental, body from head to toe. So I get you. I would say definitely somebody like Dr. Oye.
Dr. Oye doesn't have time for that kind of BS. He's a surgeon. He's
No,
laser focused.
It does.
Yeah.
It does. No, to be on the board. So that
on the
you can
board.
have on the
Okay.
board of NMA, to
Yes.
have to say, to be able to say, these are the issues, this is how to fix it, this is what you can do. And maybe
Correct.
get the government involved to even invest in some things. Maybe the government can get some C-arms. We have the money. Doctor, you laughed. You know where I'm going with that. We won't open that kind of one. But you know where I'm going with that. Just one C-arm in every district and get people trained. Do you know what that would do?
It's amazing to look at this dynamics.
I'll open a kind of one, right?
Yeah, we're in USA, and where you can go to a small community, like I'm in Beckley, and within Beckley you have other counties. All these little places have CAT scans machines. If they're in hospital like Beckley, the next doors, they have CR machines in the hospitals. You can go to I won't name one, prestigious hospital in Lekki, and which I've operated on there. And they have a C-arm that doesn't have vascular. I can't even operate on it because I can take an image and I can't see what I've taken. That's a place that if you go do surgery, they'll charge you 15 million naira for surgery. But they don't have even a C-arm that a little hospital in the most remote area of the United States does have. They don't even have the capability of the C-arm that I have in my little office-based lab in Lagos. That's the challenge that we have, So it is a problem. And for me, I've been through this role over the years. I mean, I've talked over the United States, given lectures, and but I just, as a surgeon, if I want something done, I talk once or twice with the group, and I see it's not going anywhere. I just leave and go do my stuff. That's why I don't get involved. I get a whole lot more done by myself. If I go to Nigeria for 2 weeks, I can get a whole lot more in 2 weeks than most organizations would do in 6 months. So that's the way it works.
And that's the way, if you want to get something done there, that's how you do it. For now. Hopefully that will change.
What time?
Madam VP, kindly unmute.
Yes, hopefully that should change because it's not sustainable. All of your talents, all of you guys, first of all, Dr. Zugu said to you, Dr. Oye, that, how did he put it? Short of quoting him, you have a covenant to help Nigeria. You can't quit. So, but I know that you also need support. Medical Monday is a good platform. I am very impressed about what you said in terms of people almost getting free services.
No, they are.
Yeah.
Oh,
So
some of them get free services. Some pay the bare minimum because of being rent.
Ability to pay, based on the ability to pay. Those who cannot, you're still not turning them back.
We don't turn any person away. Yeah, we don't turn any person away ever. Even in the hospital by Elsa, government hospital, they come in. If they can pay, they pay. If they cannot pay, we still treat them. They come in with a gunshot, we still treat them. They come in with injuries, we still treat them. And but if they can pay, great. If they cannot pay, it is what it is. But again, we put the non-paying portion, we roll that to the foundation. We have a 501c a foundation in the U.S. and we're able to defray some of that cost that way. Okay. Even though I have a foundation, even though I do all the things for Nigeria, I've never gone out there to seek funding from any governmental organization. I just do my stuff my way. It's faster, quicker. I don't have any allegiance to burden from any person. So that's worked well. Again, my key is to train a lot more people. You're right, I can't do this alone. So that's why I do training. So that way, again, it's said that 90% of our talents or potential will remain untapped. We'll go to our graves with them. So that being said, I don't want to go to my grave without giving something back. So that's why I go in and train.
Thank you, sir.
Okay.
So I'm trying to figure out how we can adopt a module because here I'm in Southern California. Looks like you're in Northern California. St. Jude's Hospital.
It's in Virginia.
West Virginia.
You mentioned Berkeley, so I thought, okay.
Berkeley, West Virginia.
Oh, there's another, okay, the other Berkeley. Okay.
Beckley. Beckley.
Okay, got it. You have an accent, that's why I didn't understand you.
What are you talking about? Huh? Have I tried the Appalachian accent for you? Huh?
Oh my God.
Take your medication twice a day.
Okay, I know you sound British. I can tell that. Those British people. Yes, so what I was thinking though, and I'm glad that you at least have some avenue to defray the cost. But what I was thinking is that maybe from time to time, a link can be shared here about, even if it's just a stethoscope, what is the cost of stethoscope? Like a GoFundMe for that special hospital, because all of the things you're saying can be verified. If somebody wants to come and visit and they can see that without exposing the privacy of who is getting care. But we would all love to do that. We've all benefited from so many things like that, that it takes compassion to be able to do it. Most people want a tax deduction or tax deduction opportunity, something like that. So from time to time, if you could just share the link. And where I'm going with that is, when I watch the TV here in Southern California, there's the Cancer Center for Children. And the parents are crying that they have never paid a dime
St.
to
Jude's.
that hospital. Huh? St. Jude's.
St. Jude's, yeah.
Yes. That they have never paid a dime because of, the support of the donors. Yes. Right. That really, really makes me feel good. I'm a perpetual donor there, but these are all the areas. I mean, I'm not going to be a surgeon. It's too late for me. So you can't train me. I'm not trainable.
Can train you.
No, I'm not trainable anymore for that. But there are other areas that we could participate. We also have an advocacy group. We have an MOU signed with the NITCOM, Abike Dabiri, Dr. O is the chairperson for that. There are so many areas where we can come together to help facilitate this coordination. So we will be talking to you some more about that. But there are other simple things that we could do to support your mission, especially given that, you know, people are receiving services with little or no pay. Thank you so much, sir. Thank you for all that you're doing.
Thank you.
Thank you so much. Thank you. I'm so glad you came. He doesn't talk, he will not tell you about this because it's not about show for him. This is just the reality on ground. That's Dr. Oye. Dr. Izugu, kindly unmute. The doctors are charged up tonight.
Yeah, sorry. Madam VP always get us all thinking wide.
I know, she gets us all rattled up.
Right. So and in that vein, I was just going to find out, Dr. Oye, is your procedure even covered by the National Health Insurance, Nigerian National Health Insurance?
I don't think so. I don't think so. But I don't, for what I'm doing right now when I go, I typically just treat the patients, and most of these patients don't even have any kind of insurance in the first place. So, you know, the difference in Bielsa, though, Bielsa, what had happened, the previous governor, he instituted a Bielsa insurance scheme, and that works for all the government workers in the state. So they automatically are directed to different hospitals within the state. And with that scheme, if they get ill, they go for their wellness checkup, the government pays a token amount for that care. So that it's that money that's raised, whatever it comes in like 2, 3, 4, 5 months after they're seen. That's that money that we used to pay salaries from before the workers there. But we're not making any profit, and we're not profit driven there at all. So when patients come in, we treat them whether or not they are members of the scheme or not members of the scheme. So that's only a portion that work. But again, for in the vascular surgery portion, no, it's not. It's not what the government can afford to pay at this time, as far as I know.
Yeah, so I bring that up because, you know, many a time this insurance can cover preventive services.
Correct.
And even a patient education. And if there's a way, you know, for us through this forum, can really try to push to expand that, making that coverage very easily accessible. The reason why I say this is this. They have in national health, when we open up HDPTC, that time they weren't covering even cardiac anything. And then it was only limited to workers. And then, of course, by God's grace and all the wills and whatever, it gets expanded where anybody can buy into that. So, which is a big expansion, and that was excellent. But now what is a problem is you can, let's say in your facility where you're doing that care, you may even want to do preventive education, preventive care within your facility in Lagos, but they will not approve you to have the patient to have access to have insurance to come to your facility until whatever their reasons may be. They may want to have 10 facilities like yours applying in that location to them before they can send somebody to come and accredit such a situation, which will never happen.
Sure.
So, you know, you have certain barriers that they create that makes people's access to that insurance to even preventive services very difficult. And I'm just wondering what if we can, something we can do from throughout this forum to see if there's a way to really make a change in that, where people can really buy this insurance and go get care, not letting the national health determine what, you know, whenever they come to a place before they can say, yeah, people can go get care. People need care now, not whenever you choose you want to get a place, you know.
Yeah, it makes sense. I agree with you on that. Makes sense. What we've done, one of the other things that we've done, regard to making sure the people have access to care. For example, I'm in the US and somebody has this critical limb ischemia, say in Port Harcourt. They go to one of our affiliate doctors in Port Harcourt. They're seen, they're evaluated. They will automatically send me a CT scan or CT angiogram. and give them advice. This is what we ought to do. This is what we ought to do. Then, based on the complexity of the problem, then we decide when to treat. It could be medical treatment alone. It could be intervention at some point then, or it could be intervention later. So being able to do that, which what Madam VP had mentioned, ultimately you need, even if you don't need to have a registry, you have an access where there's so much greater awareness. Somebody has PAD, they have PAD problem in Abeokuta, they know if they call this number, they'll be directed to the closest hospital to them that will manage the problem. If that hospital can't manage it because that hospital is part of a network, that hospital now would direct them to the next hospital where they can be taken care of. Ultimately, patients are taken care of. So that's one of the programs we have. So we have, like if the patient's in Warri, it's not a problem. We have network Warri, Port Harcourt, Abuja, Lagos. So in that way, we've been able to do that. And patients, when I go to Lagos, people travel from Enugu to come to Lagos, have their surgery, and fly back to Enugu. Not once, not twice. And people come from Abeokuta, Ibadan. People come from Warri. So again, when I'm in Port Harcourt, if I physically go to Port Harcourt and I see patients in Port Harcourt, they don't have to come to Lagos. And if I go to Bayelsa, it's like I'm in the United States because my operating room there is like the US. I have nice equipment like the US. I like to operate in Bayelsa because number one, it's cheaper for the patient. If a patient comes from Lagos, where they would have done an operation, say for 5 million, they can get that operation in Bayelsa for 1.5 million. They can still save 3.5 million. That's the benefit of us having ability to control the narrative of the hospital, because we have a concessionaire with the government. In 2017, the hospital was at that time inaugurated by ex-president Obasanjo. But from that point on till now, the government has not fulfilled any of its promises. I lost my personal money doing things for that hospital, which is a government hospital. Until today, the government has not paid me one penny, back. They owe me hundreds of thousands of dollars. So
Wow.
again, it's not about me wanting to make money. It's my being wanting to make sure people don't die. I can tell you, we all have sad stories. My father died in Nigeria. My mother died in Nigeria. My father came to the US, had a bypass surgery, ischemic leg, critical ischemia, was fixed in West Virginia. I want to go home. I want to go. Goes home and went back to Lagos, and he had a problem with breathing. But took him to a big hospital in Lagos. They didn't have oxygen.
Huh.
They took him to the hospital and he died. Okay, so what's my motivation to go back to Nigeria is the fact that people should not die that don't need to die.
Unnecessary deaths.
I mean, and again, my mother had a problem in Bayelsa at that time. And at that time, the government, I say government doesn't work. Government has a diagnosis center that's top grade, like US level, beautiful diagnosis center. It wouldn't pay the people that run the place. They feel that you must all bring Indian people always to the country, and you can't afford to pay them. So they order these people to go close shop. So there was no CAT scan to take care of when she had a stroke. So by the time you have to take a Port Harcourt, come back, eventually she died. It's not feasible, and government, some of these things that we need are not that cost prohibitive. If I have 1 million US dollars, I can change the healthcare system of any state in Nigeria, any
Yep.
state. I'm doing my program in Lagos with less money than I would do in the United States. I mean,
Yes.
it works. I mean, it's something that we've perfected, we've tested it, it's proven, we'll make it work. So if I go to Lagos now, I can do what I do in the United States in an office-based lab.
Yeah.
And the patient will leave that place the same day, would not sleep in that place. They'll go home to their bed the same day. That's what we're talking about. That's how you can change healthcare. But your point's well taken, Dr. Zuku, because like I said in the talk, prevention is better than cure. We have to prevent this problem up front, so we're not spending so much money on the back end of it. So prevention is important. So that's where awareness comes in. So if somebody's having leg pain, they need to know I'm having leg pain. Don't say it's somebody in the village that's doing you. You have to go seek help. Don't go to the pastor to pray for you alone or the imam, and don't go seek help. Then by the time they finish praying for you and take all your money and you're broke, then you come to the hospital and your leg is gangrenous. I can't help you. It's too late. That's the problem. So awareness, education, it has to be a constant way. And for me, it's awareness, education, not only train awareness for the patients, but also for the healthcare professionals to know that they have an ischemic leg. Because even in the US of A, I have ER doctors, trained ER doctors, board certified ER doctors will go to some person comes to the ER and miss the fact that somebody has an ischemic leg. And the patients trust their doctors. When you go to the ER, doctors say, oh, it's your back, it's a sciatica, and you have a cold leg, you trust your doctor, you go home. And a week later, your leg gets worse, you come back again, it's time to cut your leg off. That's not what we're trying to prevent in Nigeria, because we've seen it firsthand in the United States. We're still seeing it in the United States. We want to make Nigerian story better, and that's unfortunate.
No, thank you very much for that. And I like the idea of the team that you guys have. Is similar to the Global Association of Benevolent Practitioners, which we do in HDPTC. And if there's a way to team up in that sense, even if it's just for referral of patients when they get diagnosed or when they have problem, let's talk and see how we can expand that. That'd be good.
Sure.
Fantastic. Thank you so much. My sister Reganite, Oluwatoyin Fekoya, said, thank you so much for this informative and excellent lecture. God bless. Before I ask you to give us your closing remarks, there's something you need to know, Dr. Oye. There are things going on here in our DMV area. I have on the platform tonight one of our most precious son of the soil from back home. He lived here before, award-winning head honcho and disruptor Efizi is what it's called. He's a creative director, DJ, documentary filmmaker, life lover. He did the documentary on brain drain from Nigeria, and you talked about that in your talk. And then he did brain gain, because some people are going back like you, like me. We are not going back yet to stay, but there are some that have gone back even now to stay. We know some of our big unchas here that have done that. So he did that. And now he just did another documentary. Collins, are you on? Are you on? Is he on? He just did another documentary and is hearing that this Saturday. He's not on. I was
just on a few minutes ago.
It was, yeah. I wonder if it's technology kicking his behind.
Network.
But yeah, network. But thank God I got. Let me see if I can share here. You know, Zoom keeps changing its settings. I don't know why it does that. You need to stop that. Okay.
They're using AI, so.
They're using AI. Is that what it is?
Yep.
Hey. Okay, so let me see. How do I share again? It's got to show share.
Well, Collins is here though.
Collins, are
He
you?
was on an iPhone or something like that.
He was. I saw him earlier. Okay, share. This is what I want to share. This is cool.
In recent years, Nigerian immigrants in the United States have been making significant strides in the political landscape, from local council seats to high-profile positions such as state legislators and even congressional representatives. Nigerian Americans are making their voices heard.
My family and I moved from Nigeria to the United States in 1993, but I had no idea what to expect. I'm blessed to have made it to Nashville, a city that welcomed me, Zulfa Swara, and my family with love and compassion.
I was born in Nigeria, in Onitsha, Nigeria. I moved here when I was 2 years old, grew up in Arlington, Texas, then moved to Grand Prairie, Texas. And it was a blessing to run for council. I ran against an individual that was on council for 12 years. When he was first elected, I was 10 years old. So it was definitely a challenge, but we thank the Lord that we were able to defeat him in a runoff election. And I've now served the city for 4 years.
I rise today to speak on House Bill 1752 for a momentous occasion of cultural recognition, inclusivity in our great Commonwealth of Pennsylvania. At this point, it's what is the purpose of government, let alone good government. So it prompted me to, step up to the plate. A lot of people wanted me to run for some time, but I didn't feel that that was my calling. But when I prayed on it, and the Lord spoke to me and told me, go ahead and shoot for it. And I won, first round, and here I am as a state representative.
What drives Nigerian Americans to pursue careers in politics?
I came to this country in 1988 to study electrical engineering, did my bachelor's. And during that time, I've always seen the way people have looked at Africans and Nigerians specifically. But I understood that for us to really be ambassadors and people in the diaspora, we have to advocate and share ideas and culture.
My dad said, look, we didn't have the opportunity we had in the countries that we came from. But even though those are your countries, this is your country too, and you need to embrace it. And I took that fully on. When I got to college, I decided I wanted to get into politics because of just seeing how the change that they can make. I interned in Annapolis at the State House where I worked for a delegate that was young.
So my story begins with my mom and dad being raised in Nigeria, but actually meeting here in the United States at Northeast University. Rather than going back home to Nigeria, they decided to stay here and raise 5 children. Very first foray into public service was getting young kids interested in science careers by volunteering in elementary schools. And soon after, a local elected official pushed me to run for office.
Nigerian Americans are increasingly holding influential positions in state legislatures, local governments, and community organizations.
My story begins with my father, who came to the United States from Nigeria as a student. He came as a student and he immediately saw life. He had hope and he believed in the American dream. And he always told me too, like, son, put your heart and mind into everything you do, and the world is going to be yours.
Any community is defined by the wellness and inclusivity found on its streets.
Their rise challenges the norms and offers new perspectives on the issues that matter most to immigrant communities.
Nice.
Oh, this is coming up this Saturday, the 22nd.
Yeah, okay, good.
And,
Thanks for turning up.
Okay. This is not what I needed. There's, okay, right here. There is,
Mr. Collins back.
Yes, I'm here.
Mr.
yeah,
Collins
Collins
back.
is back. Okay, so can you still see my screen?
Yes, I can.
Okay, fantastic. So tickets for this is only $40. I was upset because I initially, when I said it should be at least $50, but it's $40. It's in DC, and Collins, I'm going to yield to you. It's in Martin Luther King Library, Washington, DC.
Yes,
Okay, 901 G Street Northwest.
correct.
Go ahead, the floor is yours while I play with this thing.
Hi everyone.
Hi.
I'm your. I like to call myself a documentarian. This is the my third documentary that I'm screening in the States. The first documentary was Brain Drain, which screened at AFI Theater downtown Silver Spring. And I also did the sequel to Brain Drain, which is Brain Gain, which screened at the same spot. But this time around, my creative space took me into examining how Nigerians are excelling in U.S. politics. There's one thing that motivated me to do this. A lot of us that stay out here in in the diaspora, a lot of us are not going back. And even though I'm an advocate for people to move back, but the reality is we're not all going to move back. And if we have kids and grandkids that live here, and we do not get them engaged in politics, then we're not going to be able to influence their future and policies that will help them be part of the establishment when they grow up. Yeah, so that's the story behind this documentary. And it took me to about 8 to 9 different states, and it features Nigerians in all walks of life who have council seats. Some are reps from different states, and it makes quite an interesting story. So it's coming up this Saturday at Martin Luther King Library, downtown DC, 901 G Street Northwest, at 6 p.m. And we have a special guest, the Speaker of the Nigerian House of Rep, Alhaji Tajuddin Abbas, a special guest to the occasion. And most of the council women and men and House of Rep members are also going to be. They're also going to be at the screening. So if you're in the DMV area, join us next Saturday. I think Dr. O has a link for the tickets, and she's going to post it on the platform.
Yeah, I showed it a little bit ago. I'm going to send it to your WhatsApp, to your emails, so that it can be personalized. And for people who are out of state, you still have time to buy your ticket to come. But if you can't come, call your friends, families, and acquaintances in the DMV area to please come and come see this documentary. You saw the, what do you call it?
The trailer.
You saw the trailer. I can't wait to see the whole of it. I think it's just so beautifully done. And if you think you should not get to know or get involved with politics, please think again. Think of the times we're in. It is important. It's not for you to run for office, but you will meet some of these Nigerian Americans who were interviewed. They're going to be there also, and you'll be able to meet them personally and connect and see how, like we were just talking about, how to assist the work Dr. Oye is doing. You can then ask also how to assist in how they can stay in office so we can be at the table and not be eating as menu. Saturday also, on the 22nd, you know that the Lord charged me to bring people together to praise Him and to share testimonies. It's happening the same day on Saturday, but we moved it to 12 p.m. instead of 1 so that we can still have our 5 hours. And from there, trust me, I'm going to be in DC because right after that, celebrating Christ, I'm going to DC. I have to be part of that. I have to see the documentary. And it's you'll be seeing, I'll be sending the Zoom link also. Please look out. You're going to be seeing this. Again, this is the, I hope you can see this. This is the link to purchasing the ticket. I think you have to click on the link, right?
Yes.
Okay, so that's why I have to send it personally, and I'll do that. So, did everyone still see my, oh, did you see my screen, or you were not seeing the screen anymore?
I can see your screen.
You still see my screen?
Yeah.
No,
We don't
no,
see
no.
your screen.
No, you're looking at her. She's talking about, yeah, this one.
Okay, now.
So this is a screen that I showed for the Celebrating Christ on November 22nd, same day, but we're going to do 12 to 5 instead of 1 to 6. So we can accommodate that program, the documentary. And I'll send it to you, so don't worry. This is the link to the documentary. I'll send it to you all. If you don't get it, hit me up, but you will get it.
Is it 12 to 5 Eastern or Central? Which one?
Oh, East Standard Time. It's that the virtual is East Standard Time. Sorry, ma'am. Jeez, I'll make sure that I know that on Saturday.
So Collins, I'm going to send a donation in lieu of buying a ticket. I'm not
Oh.
able to come. So
And she's in California.
Oh,
yeah.
yes, I know. Thank you so much.
Okay. Okay, that's Madam VP.
Yes, I know.
Okay.
We want to support everybody, you know.
That's your Medical Mondays family. So thank you so much for this powerful night, powerful presentation. Dr. Oye, kindly give us your parting words. Oh, thank you. Hey, before Dr. Oye goes, it's in the chat box. The link is in there for you to, just click on and to just buy your ticket. You can buy ticket for others also. You don't have to buy one. I'm buying for others. And Dr. Oye, Galaxy A03, still not telling us who this person is.
Doesn't have to be that way. It could be released right now.
Dr. O,
Oh, sorry. Kindly unmute. Unmute. Dr. V, unmute. Sheesh. Dr. V, unmute. Dr. V, you are muted. Unmute.
She's in another.
No, she's Dr. O. She was saying Dr. O. And
I'm
she
not.
said that,
I'm
but I
not.
think she will come back.
I'm not in a. I jumped out because I wanted to. Thank you. To say I'm inspired and reminded by Madam CEO's donation in lieu of coming. I will send my donation. Mr.
There you go.
Papunam.
Go Cali.
Yeah.
Go
Go
Cali.
Cali.
Aha.
I want
That's how we
competition.
roll.
Dr.
That's how we
V,
roll in Cali.
Mr. Papunam Kakime.
ando mafuma kakime.
No,
Hey, don't speak Yoruba here.
no vernacular allowed.
No,
Dalu Shindeo.
he speaks Yoruba fluently.
I know now. Exactly the reaction I expected is what I got. Thank you.
So Galaxy 03 says, and can the Nigerian doctors in diaspora form an association, NDDA, based on the trend of the contributions of the doctors tonight, especially based on Dr. Abatoye's experience with the Nigerian medical system and his sitting ECOPs. So form another association, we can start somewhere and grow thereby. I don't think we need another organization.
No,
Too many of them, and then it becomes politicized. It removes focus. We really want to stay focused, and
we find other way.
Yeah.
Dr. O, Collins, you're not on Zelle. What's going on?
On Zelle.
What is it? Email? Because I can't pull it up by your phone number.
It's three. Do you want it?
Yeah.
347 969 2553.
Okay.
Okay, great.
Yeah.
Thank you. Dr. Oye, the floor is yours, and please pardon me. I get excited about all of this.
Yeah. Well, good evening. Thank you very much for joining us today. And as stated, critical limb ischemia and peripheral arterial disease is a health hazard. That's a global phenomenon. It does not spare you because you're American or spare you because you're Nigerian. It will affect one person you know at some point in their lifetime. So that being said, it's important that we create awareness, not only for the patients, but create awareness for the healthcare providers to be able to recognize and increase the index of suspicion when patients present to them that they may have that condition. And again, finally, we also ensure that we have to improve our healthcare system in such a way that's not as fragmented. And we have to have collaborative efforts to improve our healthcare system in Nigerian and African context. It's disparaging to know. I can tell you why we can progress as Nigerians. On my last trip to Nigeria, I was close to St. Nicholas Hospital. I walked in the hospital and said, "Hey, may I speak with your CEO or CMD?" Well, he's not in this branch. I give my card. Can you give his number? Oh, no, you have to call the other number there. And oh, you have to send an email. I'm like, what? You know, That's the kind of, when you go to Nigeria, the simple things that would take for granted in the United States. If I call Dr. O, she answers the phone. She says, ABC, what do you want? Da, da, da. You go to Nigeria, you call a Nigerian physician, quote unquote, hospital, they would go through this unnecessary headache that makes you so annoyed you don't want to be part of that system. I can tell you my experience in Nigeria. That's why I do a lot of stuff myself. Many years ago, I offered free training to physicians at Lawsuit, endovascular training, free of charge, because I lived in Nigeria for 2 months. Walked in, had an appointment with the then provost, and walked in. One time he showed up 2 hours later, and the person said, "Shogbo Yoba." How's that got to do with my being present? I want to never to today never ask me what can I do, what can I do for you to help you figure out what until today. I want you to send me a CV. I humored him, send a complete CV, and didn't get a reply 11 years later. So again, those are frustrated portions of Nigeria. So PhD is important, and the vascular surgeon is important, but we need to have like thinking minds to see a problem, see how to manage the problem so the patients get taken care of. It's not about me, it's not about you, it's about the patient who needs our help and what we need to do to make sure they're taken care of, that the patient, their family don't get stressed out. And again, it can be done. I've done a pilot program in Lagos with very little financial burden. If I can do in Lagos, there's no reason why we cannot improve the healthcare system by making that platform work and then expanding that concept around the country, even without governmental involvement. So thank you again for coming, and I appreciate it. I'll talk to you. If you have any questions at any point, you have any family members, friends in Nigeria or any part of the world, you need advice, please call. We'll direct you. I have friends all over the world. Doesn't matter where they are. We'll find you an vascular surgeon to manage the problem. Thank you.
Thank you so much. Thank you. Dr. Alu says, thanks a lot, Dr. Oye.
Thank you.
Dr. Veronica says, thanks a lot. Dr. Alu says, thank you for your information and for defiling all the odds to impact Nigeria's health system. Galaxy A03, I feel like not even reading this because we don't know who you are. You say, thanks for the advice and decision on NDDA. That's the association that we don't think will be helpful. But you said, but if we keep looking at or keep creating mountains before they exist, they may seem to be not quite ready. Whichever way, let us grab the bull by the horns, and the time is now, please. We 100% agree. People are dying unnecessarily. That's true. And Galaxy A03, thanks, Dr. Oye. God bless you and all that you do. Thank you. But I hope you heard what he said last, that when he even volunteered to train, it was asked, do you speak Yoruba? And he was asking, he speaks excellent Yoruba, by the way. And, and that was the end of it. The assistance was not accepted. So guess what we do? We do it other ways. We don't go through institutions. We're working on the center right now to get it done so we can get people trained. Thank you for your passion, and thank you for caring so much yourself and for knowing that people are dying and things need to be done. We're doing it the best way we can so that we can cut the chase and don't allow people to keep dying when some people are working on bureaucracies. So we let them work on it, and when they're done working on it, we'll be there. My cousin Adesola Olaleye says, big manism, that is our problem. Big manism. Wow, that's a new word for me. I agree. Dr. Adijat said, thank you so much, Dr. Oye, Dr. O, blessings. And Adesola says, they feel threatened because you are perceived as wanting to take food from their pocket. Greed. She's right on the money. Because Dr. Oye, when you went there to say you want to train, they want to know If you charge something, if you can go into their pocket, they know you are not interested in it. They want to fill their pocket. If you had said, I'll do the training for free, but you can charge them 500,000 or 1.2 million or whatever, and it goes into their pocket, it will get done.
Not only that, they feel inferior.
Yeah.
Yeah, we have to develop a spirit of collaboration. Over the years, I've been able to
Exactly.
have many people do that. I can give you a classic story. Because I go every 2 months. I went to, I think, a big hospital in Lekki, and while I was there, I was invited by Dr. Sanusi, and while one of the doctors was taking care of a famous Nigerian artist, Mr. Ibu, right? The one he had a problem with his leg, and I was there. I could have helped him at that time, but the Nigerian doctor, I talked to him. He never asked for help. They messed around and around with the guy for about 2 months, and the guy died. I mean, that's some of this guy is so arrogant, and they don't feel like they need to ask for help.
Ego.
I mean, it's just stupid. I could have helped you out. I'm not going to charge you anymore for helping, giving advice to help you help a patient. But again, that's what happened. I left that hospital, came back to the US, went back on next trip. The guy was still there, eventually died. Should not have happened. But that's what happened. That's
what Dr. Ezugu said, you know what Dr. Ezugu said? He said, this is your ministry. You cannot abandon your ministry as a covenant. See, the motive that people have hospital is different. You're on a different level. You don't have to leave America to go and do stuff in Nigeria. But there are some people that they open office, like somebody said, greed. It's all about dollar sign. And I'm not saying everybody should work without getting paid. Of course, you should get paid because you don't sustain it. But if that is your primary target, you're not going to even think of options to help somebody because compassion is out of the window.
Yeah.
So you can't quit. So that's what Dr. Ezugu said.
Yeah.
Regardless of
He's not planning on it. He's not planning on quitting. It's, I think it's articulating what is on ground and
understood.
How we can all come together.
Collaboration is the key to success. We can do well. Nigeria is a great country. I have a great upbringing in Nigeria. I'm nostalgic about Nigeria. I go there. I feel I'm happiest when I'm in Nigeria. Believe it or not, I'm happiest when I'm in Nigeria. People can't figure why I like to go.
Yeah.
I work hard in the US. Since I came back on the 20th of last month, I've worked every day. And when my 6-8 weeks is up, I go back to Nigeria. The best time is travel from Atlanta to Lagos. Best time of my life. My brain stops. I'm able to think. I get to Nigeria. I work. It's a different pace. I don't mind doing it. I'm happy. They feed me. I've never driven a car in Nigeria from my childhood.
I know your driver, and it's amazing.
So I go. They treat me like a king in Nigeria. So why I have to go back all the time?
So you're getting some indirect perks. Okay,
Yes.
got it.
And you know what, Madam VP, his driver is just awesome. And then I found out that he's related to me. He's probably related to you too. So,
Dr. Oye, when did you come to America? Your accent.
1980.
Wow.
August 1980.
Yeah.
Cool.
And
so, Collins wrote, "Thank you, everyone, for letting me into your space. Bless you all. And thanks, Dr. Oye, for the work you do." He said, "I learned so much tonight. And thank you so much, Madam Lara, for your donation."
Mr. Collins, we need to do an awareness on PAD.
Yes, all of it. Don't worry, we're coming. Dr. B, we're coming.
Did you hear that, Collins?
But that's what NEPAC does. That's what NEPAC does.
He said you need to do awareness on PAD documentary.
Yeah.
On mute.
Oh, yes. Yeah. Thank you so much, Dr. Oye. Thank you so much. I'm ready when you are.
The campaign on it?
Okay.
No. NEPAC is in the middle of this. Hey.
Okay. I'm sorry.
You have to go through NEPAC.
Okay.
Dr. O, is Akpapunam a member of your DMVDP?
Yes, ma'am.
Yes, she is.
I wanted to catch you here right now.
Yes, he is.
I've been a member for the last 2 years.
It was a trap question, but you escaped. That's our chairwoman in California.
Yes, Madam CEO. Love you.